Hi, and welcome to Grand Rounds. Today we're going to be talking about refractive errors and how we fix them. I'm Darryl Lewis from Ophthalmology over at Langley Eye Surgeons. So the goal of the eye is to focus light onto the retina. Light from distant objects is grossly parallel as it enters towards the eyes, and we have to go through a little optical physics here, or else none of the rest of this is going to make much sense. When light rays enter parallel towards the eye, an eye that focuses light well onto the retina will come to a point. This is called emmetropia, and the eye naturally develops towards this state. When we're born, the eye is hyperopic because it's a very small eye, and the eye grows as we age. Here we can see the natural states of most eyes. This is emmetropia, where the light rays are focusing well onto the retina. In hyperopia, the lens and the cornea and the clear window of the front part of the eye are not sufficiently powered, and light cannot be focused onto the retina. It's actually focused behind the retina, and the eye is not able to generate a clear view. This is called farsightedness. With myopia, it's the opposite. The eye's curvature is too great, both the cornea and the lens together, and this focuses light to a point in front of the retina, and this means that the patient can't see well in the distance, and we call this nearsightedness. So what's really happening when someone sits behind the phoropter and you get sort of this what's better, one or two? Well, inside this is thousands and thousands of little lenses, and each of these little lenses is rotated in front of the eye. And as we go, what do you prefer? One or two? We're trying to force light, which is grossly from infinity, 20 meters away or so. So for all intents and purposes, anything beyond 20 feet or 6 meters is considered infinite distance away. That's your far distance vision. And this isn't quite true, but it's a close approximation. So you're putting back and forth all these different lenses until we find a lens setup that gets the light focused onto the retina. So in myopia, for instance, these parallel light rays from 20 feet or further away is focused in front of the retina. And we're trying to get it so that a lens in front of the eye will create a little bit of divergence, spreading the light rays out so that they're focused properly onto the retina. So what do? We put up a lens that's of a certain myopic strength, and that diverges the light until it hits the retina, okay? We may overestimate this, and we may put the light behind the retina. And then we may put in a lens that's actually a plus lens, saying what's better, one or two? And in this case, the light is bent too strongly and is in front of the retina. And we continue this process, 1, 2, 1, 2, 1, 2, until we find the right strength of lens to place the light onto the retina. And that's what the glasses prescription is. We have to introduce another concept called presbyopia. So light rays that are entering from infinity far away are parallel, but light rays that are up close to you when you're talking to someone and their face is right in front of you, those light rays are divergent. Okay, so in presbyopia, even if the eye was totally normal and emmetropic, light rays that are close to the front to the front part of the eye are divergent, and the eye has to add sufficient power through the lens in order to focus it on the retina. Okay, remember this eye was set up to be able to focus light that was coming in parallel. It has to work harder when the light is divergent entering towards it, and that comes through the lens. As we age, the lens becomes hardened and is unable to change its shape, and as a result, when light passes through, it cannot sufficiently become rounded enough to focus light onto the retina, and light is focused behind the retina. We have to place a plus-powered convergent lens, those are your over-the-counter readers or cheaters, in front of the eye to add a little bit of convergence to that divergent light. So light that was divergent is now more or less looking like it's straight ahead, and the eye, or it's parallel, like it was from infinity, and that emmetropic eye is able to focus the light onto the retina. And presbyopia really starts to kick in around the mid-40s. So normal eye, light is entering, and you're able to focus it to a single focal point. But astigmatism, again a new concept, means that there are multiple focal points. So light as it comes in, you're not dealing with a perfectly spherical situation, and you get multiple focusing points. This is quite complex, but if we think about it like this, you've got these parallel rays of light, everything comes to a point. In astigmatism, there are two curvatures. You have one power of a lens in one direction and one power of a lens in another, so they cannot form a point. Here that's represented by two separately curved lines, and this means that you get a blurred circle in the middle rather than a point, and that's what astigmatism is. Anywhere along these different pathways, called the conoid of Sturm, we get different sort of shapes of light. And instead of coming to a point, it comes to a larger circle called the circle of least confusion. And this is a little bit of a diagram explaining the same thing. These are just rods, and all the rods come to a point. There's no astigmatism in this system. If you look at a system that has astigmatism, it never comes to a point. It always forms these large disks. And you can imagine that the resolving power of something is better when it comes to a point rather than these large disks, which is why someone with astigmatism, even when corrected, will not see quite as well as somebody with no astigmatism. How do we measure astigmatism? Well, there's many different ways, but the most common way is something called the Placido disc topography. And this is where we shine rings, literal rings, onto the surface of the cornea and image the bounce back light. And this creates maps that look like this. This person has a lot of astigmatism at 7.3 diopters, but it allows us to quantify how much and on what angle the astigmatism is aligned to. We can also take images of the surrounding blood vessels and the iris to register this astigmatism, and we can pass that into the operating room. It's really important that we capture measurements correctly. Here you can see I'm up at a topographer. I'm looking at those rings. They're reflecting off my cornea and it's being captured and turned into a map. When my head is straight, it looks like it's on this angle. When my head is tilted, it looks like it's on a totally separate angle. So like I said, this is actually the heads-up display that we see through the oculars of the Callisto operating microscope that we have here in Langley. This is a cataract operation and a lens is being implanted, and the lens is implanted on the 51-degree axis. So that line that we measured at the topographer is then translated into the operating room to tell us where to align things to. If you were having laser refractive surgery, we're using a laser to correct the glasses prescription rather than cataract surgery, such as in PRK, LASIK, or lenticule extraction, you might see something that looks like this instead, where numerous points on the iris are registered preoperatively through an imaging device, and the laser is correlated to those imaging points. And so we know where the astigmatism, the rotation of the astigmatism and the alignment of the astigmatism is due to the rotation of these points, or due to the rotation of these blood vessels. So we've now gone over myopia or nearsightedness, hyperopia, farsightedness, and astigmatism, which can coexist with both myopia and hyperopia, as well as the concept of presbyopia. So how do we get rid of them, and how do we achieve emmetropia, that natural state where light rays from infinity are able to be focused naturally onto the retina? Well, refractive surgery is rapidly becoming a 1 to 2 year fellowship of ophthalmology. So I think it's not something that we can touch on every aspect of right here in 1 hour session. But this is sort of the way I think about refractive surgery these days. And grossly, you can break it down by age, because remember that presbyopia comes in this mid 40s to 60s, and above 60, we start to develop cataract. Most people who are looking for laser refractive surgery are in this 18 to 45 age range, and most people are myopic or nearsighted. Farsighted people can add power to their eye, and they do not have problems until they get into their 45s and 60s, unless their hyperopia is very high. So grossly, we're talking about myopic patients. And in the range of minus 1.5 to 9 diopters, this is the first number in the glasses prescription, we like to do SmartSight lenticule extraction, and I'll go over what that is in a little while. I'm actually doing SmartSight lenticule extraction for the first time in BC, any lenticle extraction being performed right at this very moment, and that's why I'm not giving this presentation to you live. In a thin cornea, we want to do PRK or ICL, an implantable contact lens surgery. In hyperopia, we want to do LASIK surgery. As we get a little older, we can add in refractive lens exchange, which is really the same steps as cataract surgery before someone has actually developed a cataract. When you're 60 plus, if you've developed a cataract, we're doing cataract surgery with various types of lenses. And if your cornea is very strange, as in there's an ectasia, like keratoconus, or scars or dystrophies, or a previous transplant, or previously messed up laser refractive surgery, we have to do a therapeutic treatment. So what does the toolbox look like? This is the recently purchased Schwind Atos, a femtosecond laser, and Schwind Amaris, an excimer laser. And these two things do different surgeries, and they work together at times, and I'll go over that. We also have the EVO ICL. This is an implantable Collamer lens that sits in behind the iris, but in front of your own natural lens. For ectasias and other problems, we have a cross-linking device, and then we have IOLs that we place in the OR during cataract surgery and refractive lens exchange. There's a lot of different contraindications, and I'm not going to go through them all, but some things are like being pregnant. We just don't do surgery when people are pregnant because the cornea can actually change shape a little bit, and then you can have an unstable glasses prescription. There's some medications that preclude you. There's some ocular conditions, and certainly if having things like severe dry eye or corneal scarring or previous HSV, these things can exclude you. All right, so when we're talking about refractive surgery, most people are thinking that we're talking about a laser refractive surgery, and that means that we're doing a laser to the cornea. PRK has a very wide range of surgeries that it can, diopter ranges of glasses prescription that it can do. PRK was developed in the 1980s and is the oldest of all these treatment options, and there are reasons to move away from PRK, and I'll explain those. LASIK was developed in the late 90s to overcome some of the limitations of long healing times and haze from PRK, and LASIK took the world by storm. Everybody wanted to be glasses free. The procedure works really well. It's quite safe and effective, with the biggest drawback really being dryness of the eyes. And then SmartSight lenticular extraction, or lenticular extraction in general, something called SMILE surgery, a small incision lenticular extraction, was developed in the late 2000s and is really starting to take over some markets for very good reasons. So what is PRK? So photorefractive keratectomy means that we're removing the very surface layer of the cornea called the epithelium. So we're making a removal of the epithelium, usually through manual debridement or an alcohol delamination. And we're applying an excimer laser, that's Schwind Amaris, in laser pulses, so tiny little pulses of energy that basically ablate or remove a tiny amount of tissue on the micron level at a time in tiny little spots. And we're applying millions of spots all over the surface of the cornea in a programmed pattern. And that programmed pattern reshapes the cornea through removal of stromal tissue. So you're applying the laser and removing stroma and removing Bowman's membrane, working on these upper layers. This is what it looks like. You can use a sponge or a ring. This is a well, so you put a few drops of alcohol into the well, and then you remove with a spear or with a small blunted blade the surface cells, exposing the underlying Bowman's membrane, and then you apply the laser to the bed. The big problem with PRK is that it's very painful for the first few days following the surgery. Usually 3 to 4 days after the surgery, most people rate the pain somewhere between a 2 and a 4 out of 10, which doesn't seem that bad, but there are people who can get up to pain of an 8 or 9 out of 10, and they can really be quite miserable as a result of this. Slower healing of the epithelial surface means that there's a very long delayed visual recovery, and sometimes people recovering from PRK don't hit their final vision until 6 months following the surgery. If you get a delayed epithelial healing and closure, you can end up getting some haze, which is what you're seeing in this cornea here, epithelial irregularity and haze directly over the pupil and the visual axis, which is unfortunately usually where it happens. And you have to be on steroids for a very long time, at least 5 weeks, but most people go longer, even up to 3 months, and that can lead to glaucoma. And this is what prolonged inflammation and haze can look like down the line. This is the pupil that we're seeing, and you're seeing this sort of frosted glass appearance to the cornea. Unfortunately, this kind of scarring is very difficult to treat. Usually it means that we have to do another laser, and sometimes the haze and scarring just comes back with a vengeance. So because this can lead to significant problems, we need to look for other options. What is the utility of PRK and why do we still do it? Well, PRK is very good in particular settings where there's a thinner cornea and that person is at higher risk of corneal ectasia or warpage and distortion from weakening of the cornea. If they have a higher refractive area, if they have something called epithelial basement membrane dystrophy, which is a lumpy bumpiness of the surface cells, and a looseness of the surface cells, then removing the Bowman's membrane sometimes is a treatment for the epithelial basement membrane dystrophy, and so you're kind of killing 2 birds with 1 stone. We often like to retreat corneas with PRK because it's a simple intervention when it's a very, very low prescription. And if the patient has the inability to tolerate the suction ring for a femtosecond laser, say they have severe claustrophobia, then sometimes we'll do PRK for them. So what is LASIK? LASIK is the creation of a flap. So nowadays we're using a femtosecond laser, but you could use a blade in the past. So suction onto the cornea and then a blade making a partial thickness cut. So that cut is in the anterior portion of the stroma. So we're not removing the epithelium, we're not removing Bowman's membrane, we're making a cut just below Bowman's membrane, usually on the order of 100 microns to 120 microns. We're reflecting that flap backwards. Okay, so there's a hinge at the top. We're exposing the underlying stroma, and then we're using the same excimer laser and those tiny little pulses of energy to reshape the underlying layer. We then take the flap and set it back down. Some people will call this LASIK procedure sub-Bowman's keratomileusis, SBK, and this was a marketing term introduced in the late 2000s, and that was because of the development of this very specific IFS laser, and for all intents and purposes you can ignore this term SBK because it's a purely marketing thing, but it has made its way into common vernacular, so I think it's important that we mention it. So all flaps for modern LASIK surgery are between 90 and 120 microns. Thinner flaps does mean a slightly lower incidence of severe dry eye, ectasia, and the big drawback to having a thinner flap is that you can get more wrinkles in the flap because it's very fine, and we call wrinkles in a flap striae. They also have, thinner flaps also have a higher rate of developing holes in the flaps, or developing something called a free cap, where the flap is actually just taken all the way off, and that usually only happens with a microkeratome. So who are good candidates? LASIK candidates are up to a -10 treatment, up to a +3 for hyperopia, astigmatism up to 6 diopters, an age range of 18 to 55 with a stable refraction and an adequate corneal thickness. They have to have normal scanning of the cornea. If the cornea is too steep or too flat, they can't have it. The cornea is too thin, they've got a cataract, keratoconus, EBMD, moderate to severe dry eye, advanced glaucoma, diabetic retinopathy, or unrealistic expectations, they are non-candidates. So LASIK versus PRK. So LASIK has some distinct advantages over PRK in that there's less pain, there's a much faster visual recovery and stabilization. Often people after LASIK surgery are seeing 20/20 on post-op day 1, and the final vision usually arrives between 1 week and 1 month. There's no need for prolonged steroid use, there's minimal inflammation or haze, and there's lower risk of infection. The disadvantage is that there's a higher risk of ectasia, which is this condition where the cornea becomes warped and distorted because it's been weakened too much by the laser and the flap creation. And the flap creation really does create the greatest amount of weakening of the cornea. You can get flap-related complications, like the flap has striae, which we already mentioned, the wrinkles and folds in it, which can be visually limiting. But in significant trauma, you can actually have a dehiscence of the flap and loss of the flap. Because of the flap creation, there's a large incision, and they're at higher risk of dryness of the eyes afterwards because you're cutting all the corneal nerves and they have to regenerate, usually hitting about 80% of their preoperative density by 1 year. And then you can have interface complications, and this just means you can have debris in the interface, you can have inflammation in the interface, something called diffuse lamellar keratitis. So this is a lot of the things we already talked about. You can get cells from the surface epithelium growing in underneath the flap. Overcorrection and undercorrection and regression all mean that you have to retreat, either as a PRK or lifting the LASIK flap and treating underneath. You can get glare and halos, and this happens from a reshaping of the cornea and some more complex discussion. We already mentioned ectasia. You can think of ectasia as basically inducing a keratoconus. You can get something called corneal neuralgia, and this happens with any surgery, including PRK. And then, of course, there's always the risk of infection, which is exceptionally low. Here you can see these sort of oblique running folds in the cornea. It's actually just folds in the flap itself. And this can definitely lead to a glasses prescription as well as very poor vision with a lot of nighttime glare and halo. And you do have to relift the flap and smooth it out in order to get rid of these. And you need to do it early, as quickly as is possible. This is what epithelial cell ingrowth looks like. So this is the edge of the flap here, and cells have grown underneath the flap and are creating this little nest of cells. And as they die, they become kind of white. And if these cells march towards the center of the pupil, you have to relift the flap and remove them. Very rarely, they can secrete enzymes that break down the stroma of the cornea in the flap above it and lead to flap melting and irregularity of the flap and irregular astigmatism, which then causes problems with the vision. And we put that under this corneal melting category. Diffuse lamellar keratitis is this haze and inflammation inside the interface of the flap. Can happen from a lot of reasons. Some of it is related to the meibomian gland secretions, the oils that are naturally in your tears. The problem with diffuse lamellar keratitis is that it can develop even years down the line from, say, having a corneal abrasion from a small trauma. The inflammation that's caused by that can track into the interface and cause significant problems. Ectasia is where we get this warpage and distortion. So this is a very abnormally warped cornea. And you can see that there's the right and the left eye here. The left eye, this is sort of what maybe a normal LASIK ablation might look like. It doesn't look perfectly blue and centered over the pupil, which is this dashed line. Still looks kind of irregular. Maybe there's possible early ectasia in this contralateral eye, but definitely this red hot spot is completely abnormal. And the cornea should not be 37 diopters here and like 50 here. So fortunately, we screen for keratoconus and screen for risk for ectasia quite strongly. And at Langley Eye Surgeons, we've just purchased some of the most advanced equipment in the world for looking at and detecting corneal weakness ahead of refractive surgeries. Here's a case. It's kind of interesting. So this is not my patient, but a patient that was referred to me when I was living in Halifax and was the medical director of the LASIK MD and TLC there. This is the patient's pupil, the dashed line, and they've developed a clear ectasia many years after their LASIK surgery. Usually this develops as a result of eye rubbing, but certainly can be surgically induced just from overexuberant flap creation or overexuberant laser. So quite flat in the top part of the cornea at 33, normal being about 43, and then quite hot down below at over 50, again normal being 43. And when you're looking through this weird shape of the cornea, this creates gigantic starbursts and those sorts of problems. So this patient's 37 years old and represents 9 years after just having very mild LASIK for only a minus 350, which is quite a low script for LASIK surgery. And they admit to rubbing their eyes a lot. Their best corrected vision, so they can no longer see 20/20 even in glasses, is now 20/30. And there's some things that look like keratoconus, like a Fischer ring. And so we diagnosed them with postoperative ectasia, and the plan is to use a topography to guide a PRK surgery to reshape the cornea and to do a cross-linking procedure. So what does that look like? Okay, I see that my face is kind of blocking the maps a little bit, but we're mapping the epithelium, and I think this is maybe a little bit too in-depth of a discussion, but in an ectasia, you get these focal hotspots or focal thinning of the epithelium. This is the right eye of the patient, which is a normal thickness of epithelium, surface cells, after a myopic laser vision correction procedure. So 9 years later, this is very normal. And you can see that there's this very thin spot over top of where the cornea is starting to protrude. So if we align that, you can see that this thin area of the epithelium is directly over top of that hot spot on the cornea, where the cornea is very steep and very proud. And so what we can do is feed all of this information into a laser planning software. We take a topography, and the topography looks just like I showed you, with a hot spot below and a flat spot above, a steep spot and a flat spot. And so we can create a laser pattern that flattens the hot spot, flattens the high steep part, and then creates some compensation in the upper cornea. So this purple is where the laser is going to fire a lot of shots. Yellow is where it is firing very few shots, and then a lot of shots again. And that's going to correct this overall pattern that's gone abnormal in the cornea. This is very different than just treating like a -1 would be. A -1 has a very even distribution. It's very symmetric in all directions, whereas a topography guided treatment is not. It's very asymmetric in order to correct the asymmetry that's in the cornea. So this is what the map looked like ahead of time, remembering that the patient is looking through this dashed dot. That's the pupil as seen by the instrument, and very, very abnormal flat above and steep below. We apply our laser to the surface. So we're lasering over top of the really steep part, and we're steepening the flat part. And this is the final map that we get. Nice and green right in the center. quite blue above now and less yellow below. And I've got another image of that looks like. So we then perform cross-linking, which stiffens and strengthens the cornea using some riboflavin drops to lock in this new and improved shape. And so this is what the final shape looks like. It's certainly not normal, but you can see that it's nice and even and symmetric and green all within the pupil area. And 4 months post-op, this patient has now got 20/15 vision without glasses and almost no glasses prescription at all. All right. So enter lenticule extraction, which is really exciting technology and something new for the region. So lenticule extraction, instead of making a flap, instead of using an excimer laser, creates a pocket of tissue in the anterior portion of the stroma, and then that gets connected to the surface by a small incision. This pocket of tissue is a glasses prescription. It's shaped like a lens, and we go in and we remove that lens or lenticule, and that corrects the glasses prescription. So the nice part about this is that it's done through a tiny little keyhole incision, usually just 2 millimeters on the surface of the cornea. And there's really 2 machines available. The first was called small incision lenticule extraction, or SMILE, which is a copyrighted term from Zeiss. And the machine was called the Visumax. A little bit later on, we got SmartSight lenticule extraction, and there were some improvements made by Schwinn, the company who delivered the device called the ATOS. So this has been around since 2008, commercially available in Canada since 2015. It has similar safety, efficacy, and predictability to LASIK surgery and improved patient satisfaction. There's been about 7 million procedures worldwide. The really nice part is that there's no flaps, and so people who have contact sports, MMA fighters, or springboard divers, those sorts of things, don't have to worry about flap dehiscence. And because the way the laser is performed and the very small incision that's made, there's less issue with dry eye afterwards. So how is this done? There's a little cut that's made to the surface, and then 2 cuts made through the cornea. And this is what forms the lens shape inside the cornea. We go through this tiny incision on the surface. Okay, we dissect out those planes and we remove this lenticule from inside. And I've got a video to show you that. So this is what this looks like. Here is the fixation light that the patient is looking at. This is a suction system essentially that we're looking at that's going to come down and dock onto the patient's cornea as they're lying flat on their back looking straight up. And so here we are touching down to the surface of the cornea, and you're starting to see some iris. We engage the suction to immobilize the eye, and so now the eye is actually sucked up and into the applanation device. And the laser's begun. So it's cut the bottom portion of the lenticule. So this is just a layer of tissue being cut inside the cornea. Okay, it's not connected to anything yet. We're now going to make a second pass that's higher than the first pass within the cornea and completes the lens. So these are of 2 different curvatures, but they're now connected. And finally, it makes a small incision on the surface down here and releases the suction. So that was the whole thing. This is what the eye looks like now. So I'm stabilizing the eye with one hand. I'm coming in through that tiny 2 millimeter incision I created. And I'm going to go above the first portion of the lenticule and then go below the lower portion of the lenticule. And once I've delineated the 2 planes of the lenticule, I'll come in and I'll dissect out the upper plane. And so you can see this spatula essentially just connecting all these little bubbles that are inside the cornea where the femtosecond laser has created pulses of energy and disrupted tissue. Once the top part of the lenticule has been dissected out, I dissect out the lower portion of the lenticule. And there is some resistance here, but it's not overly significant. And then the lenticule is removed from inside the cornea. And that's it. The patient's vision has been corrected. That's the thin layer of tissue that is shaped like a lens, and that's enough tissue to correct maybe a -4 or -5. A higher prescription, the tissue will be slightly thicker. So this is what it looks like post-op day 1, and all these rings that you see on the surface will fade over the next 48 hours or so, and they don't affect the vision because the patient's looking through the center part of the eye. And you can see that this is the plane, this light line here is the plane of that interface where the lenticule was extracted. All right, so there are other things that can happen with this. You can get a little piece of the lenticule that's stuck inside. You can get epithelium that slide into the interface. You can get debris or haze in the interface, which is very, very rare. You can have a residual refractive error if it doesn't correct all of the prescription. Ectasia can happen. The risk of ectasia is around the risk of ectasia with PRK and much, much lower than it is with LASIK. It is possible to still have DLK or infection. It's still possible to get nighttime glare and dry eye. So a lot of the same risks are still present. They're just present to a lower magnitude. So in summary, a lenticle extraction allows for a flapless approach to refractive surgery. And lenticle extraction retains the safety and efficacy of LASIK while offering distinct advantages, including lower risk of dry eye and avoidance of flap-related complications. So really, really exciting. British Columbia has never had this before and now has it. So I'm seeing patients out of Langley Eye Surgeons, and we're having surgery at Boyd Vision Center, which is where the lasers are housed. So what we've talked about is emmetropia achieved through surgery on the cornea. So we're modifying with lasers the shape of the cornea in order to take light from infinity and focus it onto the retina. Important considerations: PRK is a longer healing time due to epithelial removal, longer steroid course, and a much longer time to visual recovery with potentially visually significant haze. LASIK has flap-related complications and the highest risk of developing significant dryness of the eyes. Smart sight lenticle extraction has a limited range. It can only treat myopic patients right now, and eventually in the future, hyperopic treatments will be available. We also have this thing called an implantable Collamer lens. Okay, so this is a good option for patients that have something wrong with their cornea or have significant dryness of the eyes, and so they're just not candidates for a laser procedure on the cornea. This is a lens implant that is passed through the cornea through a tiny 3mm incision. It's slipped underneath the iris in front of the patient's own natural lens, and it gets rid of their glasses prescription. And so this is what it looks like. It's called the Evo Vision ICL. There's a myopic version and there's a hyperopic version. So scripts that are myopic and scripts that are hyperopic. So here you can see what it looks like. It's a lens implant that's sitting underneath the iris, but in front of the natural lens. It's soft, it's foldable, and it's very, very biocompatible. It sticks around inside the eye for life, and at the time of cataract surgery in the future, we simply slip it out and proceed with cataract surgery as we would. So in summary, refractive surgery technology is continuously evolving, and we have to be able to change with the times. Each surgical technique, be it PRK, LASIK, lenticle extraction, or ICL, has its own unique indications and advantages in specific situations. To achieve the best outcomes, it's important to have all options available, and it's essential to choose the right procedure for the right patient. Cataract surgery also presents an opportunity for refractive error correction, and Dr. Neufeld is going to discuss how do we correct refractive errors with cataract surgery at an upcoming session. But I'll give you a very high level of what that entails. Instead of it being based upon people's eyeglasses prescriptions, it's based upon mathematical formulation of the lens power to be placed. And that means that we have to very accurately measure the shape of the eye. And again, Langley Eye Surgeons has purchased some of the best equipment in the world available for this. And essentially, we measure the shape of the cornea, we measure the distance from the backside of the cornea to the anterior surface of the lens, to the backside of the lens, through the vitreous cavity, and to the retina. We can even, this is an image, I know this is very blurry, but this is an image of the retina. Okay, so we can even tell a little bit about the retina. We use these dots on the surface instead of a placido disc to tell us about astigmatism and the curvature of the cornea. This is how long the eye is, the axial length, the anterior chamber depth, that distance from the cornea to the lens, how thick the lens is, and how thick the cornea is. Okay, so there's all these parameters that go in to mathematical formulas that then tell us how strong of a lens should we place to achieve a certain refractive error in the end. Now, most people want to be glasses free for their distance vision, so in this case, you know, this particular CT Lucia lens, which we don't use very often, but needs a plus 22.5 diopter powered lens to achieve a near zero refraction in the end. And if there's a toric lens required, then we get little printouts that say toric power or astigmatism correcting power and how to align that lens in order to minimize the astigmatism afterwards. And this is anterior segment images of what it looks like. So the natural lens is quite thick. It's about 8 millimeters wide and about 4.5, 5 millimeters deep. At the time of cataract surgery, we're making a circular opening in the front face of the capsule that it's sitting in. We're using phacoemulsification to remove proteins of the natural lens that have gone cloudy, but we leave the envelope in place. Okay, so the capsular bag or the envelope is still in place, and into that we slide a lens implant. Here this is an acrylic implant, and you can see it's much thinner. Okay, so it's about 1.5 millimeters wide, and that's the surgery. And so this is emetropia achieved through IOL implantation, whether that's an ICL, an implantable contact lens, or through an IOL at the time of a cataract operation. Again, we need to come back to this concept of presbyopia, and I think Dr. Neufeld will talk about this more, but a lens implant does not change shape. So we use ICLs in young patients, the implantable contact Collamer lens for young patients, because it allows them to retain their own natural lens, so that as objects near to them have divergent light, the ICL essentially is in place behind the iris to make them emetropic. And that means that they have all of their own natural accommodation left to add power for seeing up close. By doing a refractive lens exchange or a cataract surgery and inserting a lens implant that's made of plastic or acrylic material, which is what almost all of our lens implants are made out of, it doesn't flex, it doesn't move, and so it's completely rigid, and all that can be achieved is emetropia, not accommodation, and you render people immediately presbyopic. And this is a serious concern for anyone who was of an age that never experienced presbyopia before, because I'm sure some of you know that it's a very annoying problem to have. All right, that's where I'm going to wrap up for now. It's just a very general overview, and I'd be happy to answer any questions. I may not be there immediately because I may be doing a SmartSight lenticle extraction for the very first time in BC. I'm sorry there was a conflict with those dates. I was really trying to reschedule them. However, the people from Schwindetos had to come over from Germany, and there was a very, very limited range of dates available for getting certification and the necessary monitoring required in order to be released onto the world as a SmartSight surgeon. This is a fox from the Greater Vancouver Zoo that I took, quite a nice zoo that we take our kids to all the time. Thank you for your attention.